Starting off with a bit of a bang this morning, we are going for some oral inflammatory disease. So I thought I'd have a little bit of a chat with you this morning about CCUS because that is a condition that we get a lot of advice emails for at the Ralph. It's a condition that can be really quite frustrating for everyone involved. It's a condition that does not really know when to go away. It can relapse quite frequently and it can be really frustrating for carers and for you guys and obviously for the pets involved as well. So why is it important? It's something that we're seeing really increasingly in general practice, so we need to be really quite confident in recognising it. One of the main reasons that it is important is it can have a really significant welfare impact. These dogs can experience really significant chronic oral pain, which can be severe and sometimes really out of proportion for the degree of disease that we can see clinically. It's always also quite frequently misdiagnosed as well as severe periodontal disease or gingivitis, meaning that these patients can undergo repeated dental procedures without addressing the underlying cause. And the key features of this case, they can respond quite poorly to routine dental procedures, which can be frustrating for everyone. And they also can require ongoing management. So early recognition can make a big difference for these guys with how successfully we're able to manage them. So before we go any further, we'll have a look at what we're going to try and understand from this presentation. So first we will try and recognise the clinical features of CCUS, particularly in dogs presenting with significant oral inflammation and ulcers. Secondly, we will then discuss how CCUS can be differentiated from any other causes of oral ulceration, such as advanced periodontal disease and immune-mediated conditions of the oral mucosa, and then look at the diagnostic approach that can be implemented in general practice, including what further investigations might be needed, such as biopsy, and finally look at any practical management strategies that we might use dealing with these cases, such as medical therapies, dental extractions, and what long-term care we might need. So, CCUS is a chronic inflammatory condition affecting the oral mucosa. It's characterised by painful ulcerative lesions within the oral cavity, and these lesions can occur adjacent to teeth, particularly in areas with significant plaque accumulation. But it is important to recognise that these lesions are not always confined to areas directly in contact with teeth, and a proportion of these lesions can occur in edentulous areas in the oral cavity, which suggests that plaque contact alone does not fully explain the disease process. So the current understanding is that CCUS represents an abnormal immune response to oral antigens, with dental plaque acting as a potential trigger rather than a sole cause. Historically, the condition was referred to as CUPS, which stands for chronic ulcerative periodontal stomatitis, and you might still see that term used in older literature, but the problem with the phrasing of CUPS was that suggested that the disease was limited to the periodontal tissues, but we now recognise lesions can occur away from the teeth as well. So the exact pathogenesis of CCUS is not completely understood. Current evidence suggests that the disease is an abnormal immune response rather than simply a response to plaque itself. So histologically, these lesions have a lichenoid inflammatory pattern and is often seen lymphocytes and plasma cells within the mucosal tissues. Clinically, the lesions are frequently seen adjacent to the teeth where plaque accumulates, and that supports the idea that plaque is a trigger, but also we can see it in areas without direct plaque contact, suggesting that this is an immune response rather than purely being plaque responsive. So, in terms of signalment, this is most commonly seen in middle-aged to older dogs. Many dogs will have a concurrent periodontal disease or significant plaque accumulation, which supports the idea of plaque being a trigger. Commonly reported history is recurrent or persistent oral inflammation. A lot of these dogs will have had frequent dental cohats, and they will respond quite well for maybe 4 to 6 weeks, but then they'll relapse quite quickly afterwards. But scaling or extraction will often cause quite a significant improvement for a short time. Predispositions in the literature, you'll see Maltese, Cavaliers, Labradors, Greyhounds and Terrier breeds, but strong breed predispositions haven't been firmly established. in the literature. However, in practice, Cocker Spaniels are grossly overrepresented, but this strangely isn't evidence-based if you look at papers. So another useful clue is that the ulceration is often quite significantly disproportionate to the amount of disease that you will see clinically. Many of these dogs will present with carers that are recognising signs of oral discomfort or pain. They'll quite frequently report halitosis, reluctance to eat, difficulty chewing, dropping food. They'll often suggest that the dog looks like they want to eat but are struggling. So it's more suggestive of oral pain than a systemic discomfort or disease that is affecting appetite. If the disease goes on for a long time, you might notice that they are actually starting to lose weight, which is quite uncommon for oral disease. And a lot of these dogs, as we've mentioned before, will have a history of recurrent need for dental cohats with a short-lived response and then quite quick relapse in their signs. And as we've previously mentioned, the disease is often disproportionate to the amount of pain that you're seeing. On clinical exam, one of the most notable features is the presence of these inflammatory lesions that are affecting the oral mucosa. Ulcerative lesions are the most commonly recognised presentation, but they also may appear as erosions or areas of necrosis, or something called a pseudomembranous plaque or white striae that affect the mucosal surfaces. And these can resemble something called a lichen planus that people often get on their mucous membranes as well. The buccal mucosa is one of the most commonly affected sites, particularly opposite the maxillary canine teeth or the maxillary fourth premolar teeth. But another area that's quite commonly affected is the lateral margins of the tongue, and that can be quite easily missed, as these dogs can be a little bit tricky to examine conscious. But if you do an anaesthetised exam, it's worth noting these areas as well, as they can be quite obvious when you're examining these patients under anaesthetic. Many of these dogs also have got quite significant concurrent gingivitis or periodontal disease, but the severity of this is often disproportionate, and they are, as we say, significantly painful, so a thorough exam conscious can be challenging. But these contact ulcers over the canines are quite suggestive of the condition. So going back to these kissing lesions, which they're often called against the canines, they can occur where the oral mucosa contacts the tooth surface where the plaque accumulates. Clinically, you might see the ulceration against the plaque-covered teeth, but this is not pathognomonic for the condition. But if you do see it, it would significantly raise your suspicion that CCUS should be on your list of differentials. So when CCUS is suspected, a structured diagnostic approach is really important. While the kissing lesions can strongly raise your suspicions, you need to have a structured approach of clinical findings with histopathology. A full oral examination under anaesthesia is generally required, as these patients are often too painful to examine fully conscious. And during your anaesthetised exam, you must fully evaluate the distribution and the appearance of your lesions, as well as assessing the level of dental plaque and periodontal disease. And dental radiography should also be performed to evaluate the underlying teeth and supporting structures to identify if there is any periodontal or endodontic disease present concurrently. Biopsy of any affected tissues should also be performed to rule out any other causes of ulceration, including immune-mediated disease or neoplasia. And baseline blood work is always a really good idea in these guys to assess for systemic disease, and also to have a baseline if you might need to consider any long-term medical management, which we will discuss in a minute. Some clinicians use a scoring system. There is one particular scoring system called the CCUS-DAI, which can assess the severity and monitor response to treatment over time. It's more frequently used in referral, but if you have got a patient that keeps coming back, it can be quite useful to sort of monitor response and see where those lesions are going. When you are assessing these dogs, it's important to remember that CCUS is not your only possible diagnosis, particularly if these lesions are atypical. So if you're not just getting your standard kissing lesions and your tongue margin lesions, there are other things such as immune-mediated diseases. You can get pemphigus vulgaris, mucous membrane pemphigoid, lupus. These conditions cause ulceration from immune-mediated damage affecting the mucosal epithelium, and these conditions can also affect the mucous membrane, mucocutaneous junctions as well. There are also inflammatory hypersensitivity conditions as well, such as erythema multiforme, which can produce ulcerative lesions and also affect the mucocutaneous sites as well. And then you can also have severe periodontal disease, oral neoplasia, and things like epitheliotrophic B-cell lymphoma, uremic stomatitis with renal disease, chemical burns, and these are all really important other differentials because they can look somewhat similar, but the distribution can really give you clues as to which one you're dealing with. A couple of pictures here of some differentials. These are both autoimmune blistering diseases, particularly pemphigus vulgaris and mucous membrane pemphigoid. These diseases are all a result of autoimmune destruction and lead to blistering and ulceration. Clinically, these are more widespread than the signs that you would see with CCUS, and they can involve multiple areas in the oral cavity rather than just the buccal mucosa and the tongue. So I have a look at the gingiva, the lips, the palate as well. And they're not typically associated with plaque-covered teeth. So if you see ulceration that is more diffuse, multifocal, or unrelated to tooth contact, start looking for more of an immune-mediated process. And then again, these are some other options. So we've got erythema multiforme here, which is a hypersensitivity reaction. And this causes ulcerative lesions that are more of a broad mucocutaneous presentation, affecting the skin, lips and oral cavity. And then we've also got epitheliotrophic lymphoma here. This affects more of the mucocutaneous surfaces and has more of a ulcerative, erosive kind of picture and affects the tongue margins and oral mucosa. These conditions are generally progressive, not that CCUS isn't, but tends to have more of a sort of waxing, waning appearance, whereas these are generally more progressive. So this highlights the importance that you need to do a full body examination of your patient, not just focus on the oral cavity. Have a look at your mucosal body parts, your non-mucosal body parts, check the skin. And if your presentation is atypical or not quite what you'd expect, always biopsy these patients. So histopathology, when the clinical appearance is strongly suggestive, then the clinical signs can sometimes be enough for you to make a diagnosis, but if, as we say, the presentation is in any way atypical, biopsy is always really sensible. Biopsy samples generally show a lichenoid mucositis, and this is generally characterised by inflammatory infiltrates within the sample, generally composed of lymphocyte and plasma cells. Ulceration is generally seen over the mucosal epithelium. And this generally supports the fact that this is an immune-mediated process affecting the oral mucosa. So if there is any sign that this is not a typical presentation, biopsy your lesions. So moving on to management, it's a bit of a multifactorial process when you're managing these cases, addressing both your plaque trigger and your inflammatory response. First step is always managing the plaque, starting with a professional cleaning and then establishing home care when it's tolerated by your patient. Addressing periodontal disease is always really important because these teeth can act as a source of both plaque and also ongoing inflammation. So we should extract any hopeless teeth, but it's important to again remember that this is not purely a plaque-driven process. So as this is immune-mediated, medical therapy is frequently required long-term, as is management of ongoing pain. The goal is to reduce plaque stimulation while controlling the immune-mediated inflammatory response. So, first step is a thorough dental cleaning, removing plaque, removing calculus, careful subgingival scaling as well, as the plaque can sit in the gingival sulcus. And then any concurrent periodontal disease should be addressed, as the periodontal pockets can also be plaque retentive. Teeth with significant periodontal disease or endodontic disease should be extracted if they are considered hopeless, but it's important that extraction of teeth just because they are sat next to a contact mucositis or kissing lesion is not necessary. We used to recommend sort of blanket extraction of these teeth. That is not the recommendation anymore, which is sort of in contrast to the way we manage feline chronic gingivitis. They're very different conditions. They do not have the same treatment. So tooth extraction definitely plays a role, but more aggressive extraction used to be recommended than they are now. It's purely recommended to extract hopeless teeth in these dogs. The picture we've got here is a poor little dog that had horrible CCUS, but also had these terrible caries lesions. And this obviously is a very plaque retentive surface. So if you do have teeth that look like this, they need to go. That's not something you can brush at home. So you have to manage each of these cases case by case, not purely because there is a kissing lesion sat next to these teeth. Home care is really, really important for these guys, but it has to be once the acute phase has resolved. Toothbrushing, where tolerated, dental wipes, gels, plaque-reducing diets, dental chews are all super important, but these patients are really, really painful. So until we get that pain under control, they're not going to let their carers brush their teeth. So first it's necessary to focus on controlling the inflammation, and then we start getting the home care under control. So analgesia is super important for welfare, but also for getting the home care under control. So it's all has to play a part in getting these guys under control. In addition to plaque control, medical therapies are often required for these guys, and this is why they quite frequently relapse. We get the plaque under control, we extract the hopeless teeth, but we've not sorted the immune-mediated component of this disease out. Several drug protocols have been described in the literature, but the evidence base is somewhat limited. They do work very well anecdotally, but you're not going to find a huge amount of backing in the literature for these. One protocol that is recommended is the metronidazole and cyclosporin protocol. The cyclosporin acts as immunomodulatory, suppressing the abnormal immune response, while metronidazole acts as an antimicrobial with a little bit of a anti-inflammatory effect as well. And then there's another protocol described which uses pentoxifylline, doxycycline and niacinamide. These act on the microcirculation. They're also anti-inflammatory and immunomodulatory. Personally, I use a little bit of a hybrid protocol. I combine metronidazole, pentoxifylline and niacinamide. I find this the best tolerated protocol and I find it works really, really well. But it is very much personal preference. You won't find that protocol anywhere in the data. The next thing to think about is using this alongside analgesics. So when starting the medical management, in some cases you have to start it straight away. So you perform your cohat. If they've got really marked inflammation in their mouths when you're doing the cohat, I'll start the medical management at that time. Sometimes that's the full protocol. So sometimes I'll start all 3 drugs at the same time. If they've got moderate inflammation, I might just start them on niacinamide and metronidazole. If they're quite mild, I might start them on nothing. I'll just perform the cohat, I'll send them home, start the home care, and then I'll re-examine them in 2 weeks, 6 weeks, see how they're doing. If there's still quite a lot of persistent inflammation at that time, then I might start them on drug therapy. It's all quite personalised to each patient. But you might find that you start them on some medications when you're doing the cohat, you see them back in 6 weeks, they're hugely improved, you can wean them down. There's no one size fits all for these guys, unfortunately. So you do have to see what they need, taper them, and go from there. And equally, you might find you start them on one protocol and it doesn't suit them. Some dogs don't tolerate pentoxifylline well, some dogs don't tolerate cyclosporin well. So you might try one protocol, it doesn't suit them, you switch to the other one. So again, it's all about client communication, telling them that actually we might have to tweak things a little bit so that they know that this is very much trial and error. Finding what suits your dog might take a couple of goes. And then moving on to pain management. Using the drug protocols we've just discussed doesn't replace analgesia. We need to keep these guys comfortable while we're doing this. So we need to make sure that they are very well analgesed using a combination of non-steroidals, paracetamol, adjunctives, gabapentin, whatever works well for your patient. A small aside here, there is a little comment in the BSAVA that pentoxifylline can have an antiplatelet effect, albeit mild. And that antiplatelet effect can be increased using it concurrently with non-steroidals. In reality, those drugs are used together very, very frequently in these patients, and I've never seen a problem. It doesn't mean that it doesn't happen. The other thing to mention is that a lot of these patients you'll be using these drugs on are spaniels, which can be a little bit prone to clotting issues potentially. So just be a little bit aware that that can be a thing. And if you have got a patient with bleeding issues, coagulopathies, just be a little bit cautious if you're using those drugs together. Another small aside, using long-term metronidazole in any of these patients. For the first time ever, I experienced a patient a couple of weeks ago that developed thrombocytopenia as a result of long-term metronidazole use, which I didn't even know was a thing. Apparently in humans, it's a thing, and if you stop the metronidazole, it resolves. But if we're also using two drugs together, that can result in increased bleeding tendencies. It's something to be aware of. They are rare, and patient comfort is very much a priority here. But just keep it a little bit on your radar that we want to be aware that this can be a potential aside in these guys. Review these patients frequently. If you can taper these drugs, taper them, but be aware that they can also relapse. This is a chronic condition, so modifying your medical management is necessary. They can go into remission, but a lot of these patients require some degree of medical management lifelong. So your ideal situation is to have them on the lowest potential doses going forward. If we do have these patients on metronidazole, I'm sure my medic friend will probably meet me in a dark alley after this, but we do have a lot of these dogs on sub-antimicrobial doses of metronidazole, long-term, things like 7 to 10 milligrams per kilo BID, and it works very, very well. We do see a huge increase in their quality of life on these drug protocols. So practical tips are look for your patterns, look for your contact ulcers, look for the sides of the tongue, look for the contact with the canines and the fourth maxillary premolars. They're not always confined to areas in contact with teeth. They can occur elsewhere in the oral cavity. Don't forget how painful these dogs can be. They can be extremely uncomfortable even if they don't seem to have that huge amount of dental disease in their mouths. You need to do a thorough exam under general anaesthesia because they very rarely will let you do it conscious. Management should focus on addressing the dental disease, reducing the plaque, professional cleanings. It's usually chronic. You will almost always have to reassess these dogs frequently. And plaque control, while it's very important, it is not the only thing that you need to do with these guys. You need to address the underlying immune dysfunction to get these guys comfortable, and long-term management is almost always required.